Well, welcome today to today's webinar. We're very delighted to have you all join us. My name is Lydia Dugdale. I'm Director of the Center for Clinical Medical Ethics at Columbia University in the Department of Medicine, and I am delighted to co-host today's program with Dr. Barbra Rothschild, who is faculty at the Columbia Masters of Bioethics program. And we're so happy to have our two guests with us today. Before I go on and introduce our guests, I'd just like to say that the format of today's program on Rethinking Death, a webinar on brain death, the format today will be that we'll open with some conversation among the four of us, followed by time for audience Q&A. And there is a Q&A feature at the bottom of the Zoom screen here. So if you could please post your questions at any point during the conversation, we will pull those questions when we get to the audience Q&A section of today. We will try to end directly at 2 o'clock Eastern Time. So without any further ado, our special guests today are Dr. Lauris Kaldjian, who directs the program in Bioethics and Humanities at the Carver College of Medicine at the University of Iowa. There he is professor in the Department of Internal Medicine. Dr. Kaldjian received his BA from Oxford University, his medical degree from the University of Michigan, and he holds an MDiv, or a Master's of Divinity, and a Ph.D. in Christian ethics from Yale University. And at Yale, he also completed residency and fellowship training in internal medicine and infectious diseases. Our other guest today is Dr. Robert Truog, and Dr. Truog is the Francis Glessner Lee Distinguished Professor of Anesthesiology, Pediatrics, and Bioethics at the Harvard Medical School. He is also Director Emeritus of the Center for Bioethics, also at Harvard. Dr. Truog received his medical degree from the University of California at Los Angeles, and he is board certified in the practices of pediatrics, anesthesiology, and pediatric critical care medicine. Dr. Truog holds a master's degree in philosophy from Brown University. So now I'm going to hand it over to Barbra to set the stage for today's program.
Thank you, Lydia. This was such a great idea that Lydia had to convene these two great speakers, and that we can all benefit from some really interesting thinking. And I think that it is significant that we've had such a nice response to this webinar, that it's time to be thinking about brain death again. There's been a lot of technological advances, and we're probably getting around to where we need to think about this again. This discussion was proposed in response to a discussion that Lydia and I and some others had on New York's somewhat mysterious approach to brain death, which requires quote unquote reasonable accommodation. And that mysterious approach about reasonable accommodation is unclear what that accommodation actually even pertains to. Is it that someone's dead? Is it that we're determined that they're dead? And this definition of reasonable has been changing and becoming more accommodating in many ways, in part because of a couple court cases here in New York State over time. So, and it's gotten to the point that we're even asking permission to perform a brain death determination, even when brain death is strongly suspected. And when that act of determination is declined, so family might say, I actually don't want you to tell me whether my loved one is brain dead, it leads to a bit of a farcical, and I don't mean that in a disrespectful way, but hospitalization from sort of everybody's perspective. You can't place that person in long-term care, but also we can't treat the person because they're dead from the perspective of the medical team. So in addition to this situation, I think we're all particularly interested in this current atmosphere of a missing trust in our medical community, that we contribute greatly to that lack of trust when we don't ensure consistent gold standard brain death determination nationwide. Each state has a slightly different version of brain death, such that even with our neighboring state, New Jersey, you can be dead in New York and not dead in New Jersey. This leads to, understandably, the public having some misgivings over what this determination really means. And medicine seems unable to police itself in keeping its members to a gold standard determination. Finally, in some ways, this always returns to the Harvard Committee, and I know Dr. Truog will um, go into this in more detail. Is this about death or is it about organ harvesting? If it's only about death, we might reasonably remove this even idea of brain death and instead perform the determination as prescribed by the American Academy of Neurology, and then tell families that there's no chance of meaningful recovery, and then we proceed from there. We don't even go to the death determination part. Families may choose ventilatory support or not. We might want to strengthen our conviction to say no to other interventions. For instance, if this is the case, we actually don't offer dialysis and such, but we don't have to say the word dead. If this is all about organ harvesting, then if we adopted the stance above, we'd need to also drop a dead donor rule, which we will discuss in detail. And this would be a big and uncomfortable shift. I know, Dr. Truog, you've written about this quite recently and in detail. And synthetic and xenotransplantation, they're on the way, but they're not here yet. So we have a conundrum in front of us. So these are the issues that Lydia and I certainly were talking about. And I leave it to our two distinguished guests to sort of lead us through the discussion.
Great, thanks, Barbara. So, Dr. Truog, since you are our representative of Harvard University, responsible or perhaps we blameworthy, depends on how you look at it, for the Harvard ad hoc criteria, could you just take a minute to bring us all up to speed on how brain death became a legal definition of death, and then what that means for how we declare death today?
Wow, we've got so much material here. Let me try to do a 5-minute overview of what I think are the main issues at play. So let me begin. What do we mean by death? And I want to start with a scientific view of what death is, which I would take to be the loss of homeostasis or the loss of integrated functioning biologically. In any organism, and this applies across the entire biological spectrum. We can talk about dead bacteria, dead bugs, dead plants, dead animals, dead people. Scientifically, they are all fundamentally the same. Death occurs when you lose your integrated functioning. As organ transplantation developed, 1967, the first heart transplant, followed by the Harvard Committee in 1968, people realized we need living organs in order to advance the field of organ transplantation. And you're not going to get living organs from people who are dead in the usual way. And so this kind of novel idea of thinking, could we define death in terms of brain function or the absence of brain function as a way of enabling us to get living organs from individuals who have been determined to be dead. And that was sort of the situation that set off the debate. The Harvard Committee was the first to propose this idea of defining death in terms of neurological functioning. And then it became law in 1981 with the Uniform Determination of Death Act. And the criteria that we use conceptually, I think, is really clear. When you fulfill the American Academy of Neurology criteria for brain death, it very simply means that you are never going to wake up again and you're never going to breathe on your own again. This has been termed a state of irreversible apneic unconsciousness. Irreversible apneic, you're not going to breathe on your own again. Unconsciousness, you're never going to wake up again. And that brings us really to the heart of the problem, which is why would we think that somebody who has this severe degree of brain injury is actually dead? And I thought it might be helpful here to contrast the position taken in the United Kingdom versus that in the US. Because the UK has had a very simple response to that. I'll just tell you the sentence from their guidelines. Death entails the irreversible loss of those essential characteristics which are necessary to the existence of a human being. And thus, the definition of death should be regarded as the irreversible loss of the capacity for consciousness combined with the irreversible loss of the capacity to breathe. So it's a, just, hey, when your brain is really damaged, we can consider you to be dead, even though it's not true biologically. And I think this is where the United States was either very honest or took a wrong turn here, because that didn't seem to make sense to the American lawyers who created our law. And so what I was taught in medical school, was that the reason brain death is because it means that you have lost homeostasis. In other words, once we make that diagnosis, within a matter of days, you're going to have a cardiac arrest and die in the normal way. And this was the dogma that was taught in the United States all the way through. And the problem that we have come to learn is that it's false. That in fact, even with this very severe degree of brain injury, patients can continue to maintain homeostasis, can continue to maintain integrated functioning for years. It's kind of counterintuitive, but the body does not need the brain in order to maintain integrated functioning. You can take away the brain functioning and the body could just percolate along just fine. And we had a number of cases of this. It wasn't a secret, but what really brought the debate to center stage was the case of Jahai McMath, a young woman who was diagnosed as brain dead in 2013, but who went on to live biologically for 5 years after that. And all of a sudden, people started to say, well, wait a minute. What do you mean brain death isn't traditional death? This is what you've been telling us, and yet the McMath case shows that that's not true. And so more and more people started to reject the diagnosis of brain death, particularly around children. And my hospital, and I'm sure virtually every children's hospital in the country, has now seen cases like this. And so the idea was, well, maybe there's something wrong with our law. And maybe if we could go back and revise the law, we could fix these problems. And so the Uniform Law Commission resumed meetings from 2021 to 2023. I was a part of that group, and explored various ways that we might fix the law. But it became very clear to some of the commissioners that, wait a minute, brain death isn't biological death. It's a very severe brain injury. And the way that the conversation went was, well, if it's a very severe brain injury, then these people aren't dead, they're merely disabled. And if they're merely disabled, then they deserve the protections of all disabled people, including the protection against being killed. And so the deliberations of the committee sort of quickly dissolved. It was abandoned. And so we're sort of right back to where we started, where, I think recognizing that brain death is not biological death, what are we going to do? And let me just close by kind of giving my own personal view about it, is that I don't think it's unreasonable to take the United Kingdom position, for example, to say that if a person is never going to wake up or breathe on their own again, that we can consider them to be dead, that we can call it legal death. And that would be fine with me. If I were in a state like that, I'm too old really now to donate my organs. But if I were in that state, I would be fine for you to treat me as dead. And I think that would be true for many people. But I think what we need to do in the United States is we need to recognize that not everybody feels that way. And that there's going to be people who want to opt out. And when that was brought up at the meetings of the Uniform Law Commission, it was, oh my goodness, we can't possibly allow people to opt out. It'll cause chaos. There'll be brain dead patients who are filling up all of our ICUs. Nobody's going to donate their organs anymore. The whole system's going to fall apart. And maybe that would be true. But I think we do have sort of a great case in New Jersey, because New Jersey has allowed people to opt out of the definition or the diagnosis of brain death since 1991, almost 25 years. And we haven't seen any of those bad things happen. Their ICUs are not overflowing with brain dead patients. Organ transplantation happens in New Jersey just like it does everywhere else. And so my own view is, I think in the United States, we ought to accept the truth. Brain death is not biological death. But many people support organ donation, me included. And if I were ever in a state like that, and I think for many people true, where I'm never going to be able to experience life again, I would want to be an organ donor. But I think we ought to be able to allow people to opt out of that if they feel differently. I'll stop there.
Thanks so much. So, Dr. Truog, brain death does not represent biological death for you, but perhaps more of an extreme kind of disability in your view. Dr. Kaldjian, you have written that a mysterious relationship exists between the mind and the brain, and that depends on what the nature of that relationship depends on how we understand what it means to be human. All of which then complicates what brain death might be or signify. So I was wondering if you could elaborate on your concerns about brain death, and then perhaps Bob, Dr. Truog, if you could just go ahead and then respond to Lauris when he's done elaborating on his concerns. I'd just love to hear your initial response. And Lauris, I don't know if you want to start by a response to Bob or vice versa. So the floor is yours.
Yeah, how about if I first say my sort of 5 minutes worth here? But first of all, thank you, Lydia and Barbara and Bob too. I've known of your work for many years, and it's lovely to be able to be on this platform with you together. So my insights arise from medicine, ethics, philosophy, and theology, and my experiences as a physician and an ethicist. I sat on the OPTN UNOS ethics committee back from 07 to 10, and I've had a lot of very engaging discussions with colleagues here at the University of Iowa over the years on all sorts of questions related to these matters. And I should add, just as a matter of course, that my views do not represent the University of Iowa. So I appreciate already what's been said about the history from the Harvard Committee from 1968. And I've read some of the literature on the background history, and there's some really interesting publications that point out what was actually going on in those deliberations. I have no way to do other than conclude that the main driver was definitely the desire for transplantable organs. But I acknowledge that the other primary rationale that was stated was that there was a concern about ICUs getting overpopulated with severely injured, brain injured individuals, et cetera. But I've always thought to myself that if a bunch of graduate students at Harvard had gotten together to really, plumb the depths of the mysteries of death, philosophically and theologically, that would have been a very different discussion than a committee that involved apparently, I think, 2 transplant surgeons on it who were clearly interested in the question of transplantation. And specifically, a key line from that JAMA 1968 article says, from the authors themselves, our primary purpose is to define irreversible coma as a new criterion for death. That to me strikes me as a social and legal fiction, not a biological discovery. So I'll be blunt about that. Okay, so that's my first comment. I very much appreciate Bob's basically a medical dictionary definition of death as having to do with the lack or cessation of integrated tissue and organ functions. Another key point is I think that there's sometimes when people talk about the need to do brain death so-called examinations, I just as a clinician, I disagree with the need to do that kind of an examination to allow dying people to die, right? Who are severely injured or dying for all sorts of comorbid sort of reasons. And so we need to separate palliative care from the procuring of organs and matters associated with them. I think it's also really important whenever talking about organ transplantation to be thinking about what utilitarian imperatives are at play. When I was on the UNOS Ethics Committee, I remember very clearly how the 2 main drivers, ethically speaking, are justice and utility. Autonomy tends to take sort of a lesser seat in some respects when it comes to scarce resource allocation, et cetera. So I think that we have to wonder about the extent to which social drivers of what is useful for the sake of trying to sustain dying people's lives who need solid organs to survive, how much is that driving how we're redefining things? Okay, so I have a variety of a couple of core convictions. And one is, as Lydia already indicated, that I have an interest in wondering what is the question about what it means to be a person. I'm not a big fan of the word personhood, because it sounds like it's something you might be able to lose. But what is it to be a person versus what is it to be a person who has a nature? There's a long, rather ancient history to these ideas. But I would want to suggest, based on my own philosophical and theological understanding, that we are embodied souls. We are this mysterious mixture of mind and soul on the one hand, body on the other. And I think there's some very interesting, and I would say contrary sort of currents that are very Cartesian in terms of mind-body separation, but also currents that have redefined the idea of a person in terms of the person's nature or functional capacities, right? And so that if you don't have rationality, intentionality, relationality, or consciousness, that somehow you cease to be a person. And I actually think that the whole discussion of brain death is I think unfortunately and maybe inadvertently circumvented the question of what is it to be a human person. And I think we need to really continue to engage such questions. Another core sort of conviction has to do with the dead donor rule, right? This idea that U.S. law forbids the removal of vital organs for donation until the donor is declared dead. Otherwise, it's considered an act of homicide in our society. And I recognize that there are some, and it sounds like Dr. Truog is one of them, who is ready to give up on the dead donor rule, the way the UK has done that, right? I, for one, am not ready to do that because I think the dead donor rule accurately reflects a society that has a certain profound degree of respect for human life. And no matter how good and desirable the ends of saving lives may be, in my mind, it means that the means should still not be compromised in order to achieve those ends, so that the ends, no matter how good, don't justify the means. I also, speaking of Dr. Truog's work, I've appreciated the piece, Bob, that you wrote in JAM in 2020 with a couple colleagues, in which you have the line regarding the irreversible apneic unconsciousness not being the same as biological death. You then say, but should patients in this condition be considered to be legally dead? And then, this is the key line, this is a complex question that hinges on metaphysical and moral views about the necessary and sufficient characteristics of a living person. I really appreciate the candor and care of that statement to raise this question of what are our deeper foundational beliefs and values. So I already mentioned the idea of Cartesian dualism that separates the mind and body, mind from the body, but then I think also goes further to treat persons as minds separable from bodies rather than as embodied souls. And then I would just say, by way of conclusion, conclusions, that the idea of brain death, I really think, is a social and legal construct based on debatable beliefs and values. It's not primarily a concept determined by biological observation alone. And so I really appreciate, Barbara, your introductory remarks and how you, as well as Bob, are indicating that there is not only room for a reasonable pluralism, as New Jersey manifests, but actually a real compelling case to be made for exactly that, based on the pluralistic values and beliefs that reign in our culture. And so I agree that, in short, I believe brain death reflects a severe neurological injury, not the death of a person. And I think that the idea of being embodied souls or minds continues to help us think about ourselves as persons rather than as collections of functional capacities when which absent deprive us of being persons anymore. So I would recommend, I'll close with these four last bullets, that we should continue to think how best to respect and show love both to those who are injured, i.e. dying in our ICUs, as well as to the dying who need solid organs to survive if they believe that's the best way to approach their severe illnesses. And then we should also rely on definitions of death which are biologically compelling so that we don't do injustices to the English and other languages. And then to resist utilitarian imperatives and social and professional pressures to pursue good ends at the expense of unjustifiable means. And then lastly, to recognize that those human beings who are severely neurologically injured, including those who some would consider brain dead, are still persons and should be treated with respect that is due persons, a respect which is expressed, I think, through the dead donor rule. Thank you.
Thanks, Lauris. Bob, do you want to respond?
Yeah, Lauris, let me, well, first of all, beautiful comments. bottom line, when somebody is in a state where they're never going to wake up, never going to breathe on their own again, where based on their personal beliefs, um, uh, they would like to donate organs, recognizing that this will cause their death. Would that be okay? Because it sounded like your pretty firm position about the dead donor rule would still insist that that's not acceptable.
Yeah, that is correct because I mean, so it would seem my take on your position would be that I see you as, if I could say, sort of almost like a mathematical equation, that autonomy plus utility plus irreversible apneic unconsciousness makes a compelling case for organ donation, apart from the need for the dead donor rule. So I would still say that autonomy is not, choice is not self-justifying by itself, such that I would want to take a deeper sort of notion of a respect for persons that includes the prohibition on killing or ending the lives of innocent people. And so actually here I could even sort of turn this around and remind people, especially those who may not be familiar with this, but in the Canadian context, now taking this, the UK idea a step further and coupling euthanasia with organ donation. And so yes, you've heard me accurately that I believe that it's still unjustified, ethically speaking, as I understand it. But I'd be curious to hear your thoughts about that next step further on the Canadian frontier. What do you think about that?
Well, yes, I could go there, but I just really want to get clear here for a moment.
Yeah.
Is there any situation where you think procuring organs from a person that we have accurately identified as being brain dead is ethically acceptable?
No, because
Okay,
I don't believe brain death is death, and I am persuaded by the need for the dead donor rule that there needs to be a
okay.
biologically compelling definition of death.
That's what I thought you were saying.
Yeah, yeah,
I
yeah.
just wanted to
Thank you.
hear it in sort of a black and white way. Yeah. Okay.
Sure. Yeah,
Great.
any
Yeah.
comments on that the Canadian euthanasia sort of front?
Yeah. A slight little riff here. I think that one of the things we do as ethical physicians in medicine is that we often do facilitate the deaths of patients in order to serve their own goals. So, for example, when we withdraw life support, I think we are facilitating that person to die in respect for their decision to not want to live anymore in their current condition. When we administer, at least in the ICU, when I administer potent opioids to people who are dying, I'm facilitating their death in order to facilitate their own goal of a peaceful death. I think the idea that there's a bright line that physicians cannot like engage in the facilitation of death is doesn't really fit actually with the way we practice not only what we actually do practice, which we do, but actually what we think is the right thing to do. We think it's the right thing to withdraw life support when patients no longer want it. It's the right thing to give patients medications that might speed up their death when that is consistent with their ends. And I could imagine framing the procurement of organs from brain dead patients in much the same way. And I don't think that's inconsistent with some other very well established ethical practices in medicine.
Yeah, and I'll just quickly say that what I hear there is a difference that I'm certainly familiar with in terms of a more consequentialist or outcomes or utilitarian sort of based assessment ethically as opposed to something based on intention. And I would certainly, based on when I read, statements from palliative care organizations about, say, the difference between, palliative sedation versus assisted suicide or euthanasia, the role of intention is key. And of course, there can be discussions and debates about the principle of double effect. I certainly support it myself and find it persuasive, but I recognize that not everyone does. But I would still presume that at least some, and if not the majority of palliative care providers are individuals who would say that, even though I understand what you mean, I think, by the use of the word facilitate and facilitation, the intention is still to provide comfort and to allow a natural death as opposed to cause or hasten death.
Yeah, this would take us off in a whole different direction. So
we have many questions. So I'll start with a couple, and I just want to thank the audience for actually such a remarkable number of great questions. And I doubt we'll be able to get to all of them, but we can start with the very first question to Dr. Truog. So this person is asking, you morally believe it is okay to take a life of a severely disabled patient who will no longer regain consciousness or breathe on their own. And I believe what the person is getting at is not someone who's had an injury, but someone perhaps who's born in this way, looking for, some sort of bright line difference, perhaps, or maybe you'll interpret the question in a different way.
Well, I will tell you that I was very much in the minority of people in the most recent meetings of the Uniform Law Commission who gave credence to this idea that brain death is a form of disability. You can imagine why that was such a showstopper right to begin with. It was like, well, wait a minute, we've got a whole structure around how we think about disabled patients, and it certainly doesn't involve taking out their organs. I found that conceptually sound, but very few did. I mean, no, it was often framed as an extremely right-wing view, pro-life, very conservative viewpoint. And I don't normally fall into that camp, but I thought it was a compelling argument, which is why I come back so strongly, and I want this to be an important part of how I'm heard, is that I think people should opt into this with full awareness of what they're doing. And one of the reasons I think it should be permissible for people to do that is because I think we do have strong ethical motives to help others in need. Look at if you take brain death off the table, there's 10,000 people a year in the United States who are diagnosed as brain dead and become organ donors, who donate as many as 8 organs per person. That's a lot of good that's happening to benefit people who are in need. And I think that has to come into the equation too. And so I think giving people the permission or giving them a pathway in order to be able to help others through the donation of their organs has some ethical merit. At the same time, it should never be compelled. And for those who feel differently about it, I think that needs to be respected. And I think that is an area where our current practices in organ donation have really crossed a very important bright line, as we've read in the New York Times and everywhere else recently, that even just following the rules seems to be in the breach at this point. But yeah, I think that we need to look at the whole picture, not just this narrow notion of the dead donor rule.
So there's another version of that question, which is directed to Lauris, which is the question goes, I appreciate your comments that a human person with severe brain injury deserves respect and love, but to exit the philosophical and silo of bioethics and medicine, how do you, Dr. Kaldjian, suggest or advise we treat these patients? So how do we treat the patients that arguably would be brain dead according to some definitions, but are just perhaps severely injured according to another definition? Do they stay on life support indefinitely?
Yeah, I'm humbled by the power of that question, because if any of us are family members at the bedside of that loved one, as a clinician, as a family member myself, I'm just struck by that. So thank you for the question. And then what I would simply say is I would treat that scenario the way we treat countless other scenarios in medical life and in human life, right? There are many people who are in dire straits medically, biologically, neurologically. And I am certainly not someone who says that every human being should be kept alive for as long as possible. No, there is something called dying. And I recognize that talk about, I mean, here we are talking about definitions of death, defining what the trajectory of dying is and looks like and prognostication, et cetera. I'm not saying there's anything easy about that, but there comes a time, and I think certain traditions have words like ordinary versus extraordinary care, et cetera. But certainly, when someone's care requires being on mechanical ventilation, that reaches an order of magnitude and significance clinically, where it can be entirely appropriate for a family to decide on the behalf of a loved one that basically this is a condition that is causing the death of our loved one. And so we can now remove the burdens of these treatment in order to allow that process to happen. So no, I'm certainly not suggesting that all those individuals need to be kept alive. But, and this gets at the pluralistic question once again in the New Jersey context, I can also remember, I won't go into the details, but being involved as a clinical ethicist with a patient in my own institution where there was a particular request on the behalf of the family to continue to care for a certain individual under these circumstances of so-called brain death. And one of the things I'll just say that was even quite striking about that as an aside is one of the questions that a family member had to me was, is insurance going to pay for the care? And to my surprise, the insurance did cover that care. But the point being is the care team then was willing to work with the family for a few more days and clearly gave that family time to convince themselves that their loved one was dying, and then they allowed their loved one to die by extubation.
Could I just add to that? We have many, I work in pediatric ICU. I've taken care of many patients who are a whisker away from being brain dead. They're severely brain injured, but they don't meet the criteria for brain death. And they live at home on a ventilator. They're have a feeding tube. Their families love them. It goes on for years. The families have no regrets about what they're doing. They come in and out of the ICU for pneumonias and things like that. But for a few neurons, they would be brain dead, and we wouldn't be doing any of that. So I think that there's not a bright line there, and I think one of the things we should be open to around families who refuse to accept the diagnosis of brain death is that it's perfectly fine to take them home or to have them in a long-term care facility. Jahi McMath, for the 5 years that after she'd been diagnosed as brain dead, spent very little time in the ICU, actually. Most of the time she was at home with home nursing, came into the ICU occasionally for pneumonias and things like that. So I don't think we should make a stark a line here that if you're brain dead, we're stopping. But if you're not brain dead, we're going to go on forever. I mean, I think they actually are all on a spectrum. And we can see a whole variety of different approaches to how families would like to move forward.
And can I just chime in once more on that? I think what to me is interesting is that, and I think some of this conversation has already intimated as much, that the conversations about so-called futility or potentially inappropriate care, whichever terminology one wants to use, that is the space that is usually, in a sense, our training ground for these kinds of conversations with families when clinical teams and families have disagreements about what treatments are appropriate and what are not a treatment, which are not. It seems to me that sometimes, at least when I've listened in on certain conversations clinically, is that the so-called brain death determination is used as sort of a conversation stopper to force the question and say that now we don't even have to have this back and forth about is this appropriate care or futile care, but rather we're going to declare that there's no way it could under any circumstances be appropriate because we can play the brain death card. I think sorry, go ahead, Bob.
No, I mean, I was just going to totally agree with you. I mean, I think brain death, one way of defining it is it's a legally enforceable determination of futility.
That's a good line. That's a good line.
So I feel like some people in the questions are asking, are sort of shocked by the idea that what if you got rid of brain death and all the sorts of down the line things that would happen? What would happen at the DMV? How would we explain to people and I think you started with this conversation just now, how we talk to families, but importantly, talking to families because organ donation hasn't gone away, even if we decided to do away with brain death. What in practical terms would the two of you recommend as policy, or what would be our message to the public? How would we both I'm gonna add this, regain trust with the public that we've already lost? And what would it look like in practical terms? Does that make sense?
Yeah, but Bob, please go first if you would. Yeah.
Yeah, you know, as you know from what I've already said, I think that people should be allowed to donate their organs when they're in a state where they're never going to wake up again and never breathe on their own again. I think that that should be permissible. Um, what has bothered me about the brain death debate is that we've not been honest with the public about what it means. I think if you're transparent in this way and you say, you know, check the box, and if you're in this state, um, uh, you, you have indicated that you would like to be an organ donor in those circumstances, and that should be permissible. But you know, I don't think the public has any clear idea about what brain death means, and I think that well, I hope I don't get into trouble for saying it, but I think that we have contributed to keeping it vague and unclear. Uh, because we don't really want the public to know about it. We want them to think, oh, it's just if you're dead, you know, why wouldn't you want to give your organs if you're dead? Without recognizing that it's actually more complicated than that. You know, one of the reasons I haven't checked the box on my organ donor card is not that I would not want to be an organ donor. It's just that I would want the doctors and the nurses and the transplant facilitators to talk to my family about it. They know what my wishes are, but have a degree of openness and transparency and an inclusion of my family, not my family being cut out of it with somebody saying, "Oh, look at he checked that box, so you really have nothing more to say about what's going to happen to your father or your husband."
So Bob, just to clarify, if someone on this call was at the DMV, would you want the form at the DMV to say, if you end up with severe brain injury from a motor vehicle accident, check here if you want the doctors to remove your organs to make you an organ donor? I mean, how would this be communicated to the audience or to the public in a way that doesn't burn bridges and destroy organ transplantation?
Yeah, I, I don't have a solid answer to that other than it seems wrong to be making very significant decisions while you're standing at the DMV and the woman on the other side of the counter, the man on the other side of the counter is, you know, waiting for you to do something so that they can get on to the next person. You know, there's no informed consent about what's going on there, nothing. And yet transplantation is a medical procedure, and yet it avoids all of the things that we normally think are essential to important decisions about your medical care, which is understanding what's going on, understanding what the alternatives are, understanding what the consequences are going to be. None of that is true in the way that we've set up organ transplantation through the DMV. I'm not going to change that, obviously, but I think it's one of the things that I think has contributed to so much controversy that we're talking about here.
I would add, I mean, one of something we haven't talked about is one of the nice things about the AAN determination is it does we've had so much controversy and frankly some scandal around organ procurement, where we have some organizations perhaps being overly aggressive in their desire to procure organs. There is a bit of a safeguard to the dead donor rule, including the AAN determination that says, well, it has to be to this level of brain injury that
Yeah.
we would lose, honestly, if we did away with brain death. It's almost like a gatekeeper in the other direction. It protects the over procurement. If one could, like, perhaps someone isn't quite so injured, but they seem injured enough. Um, so perhaps the AAN guidelines, I mean, I'm not sure if we've thought about it in that direction, sort of help protect people
Oh, yeah.
from donating before they should.
No, I agree with you. I mean, I don't think people should, be able to come in with a minor brain injury and say, "Oh, I want to be an organ donor." I mean, I think that the AAN guidelines, and by the way, the most recent versions, I mean, they have really gotten good about the medicine. I mean, they're really clear. They're much longer than they used to be, and because they want to be very specific that before we declare you're in the state called brain death, we want to make it really clear that your brain injury is extremely severe and irreversible. So I'm right with you. I mean, we need those guidelines as a check against what would be very bad things.
Can I just say that, Barbara, I appreciate the point that I think that I hear you making, but at the same time, it seems to me that once you take that step, you're now that the logic of that move is going to declare itself in further manifestations, because it'll be perceived by some as arbitrary that you've defined the stopping place where you have, as opposed to, I think that the point about the dead donor rule is it's supposed to be non-arbitrary, right? It's when you think about biological death. I mean, when I read standard definitions, I don't scratch my head thinking, well, I wonder exactly what that means. I'm not saying that pinning down exactly the so-called moment of death or the moment that the soul leaves the body. I'm not claiming to divine those mysteries, but the trajectory of dying in terms of what this lack of loss of integration and function at the organ as well as cellular level, et cetera, that's very definable. And any clinician at the bedside, when I was an intern and was declaring patients dead, I wasn't scratching my head thinking, I wonder if my patient's dead. I knew my
Mm-hmm.
patient was dead, right?
Yeah.
There's no mystery there. So it seems to me that if you the moment you deviate from a biologically credibly persuasive definition of death, I don't see how you stop from going the direction that Canada has decided to take, where you now bring together the autonomy-centric understanding of euthanasia in a radical autonomy sort of sense, with the desire to do good to others by giving up one's organs. I'm not disputing good intentions in that sense. So don't get me wrong there. But I think it's my hunch is, Bob, would you agree that it's autonomy is it sort of rises to the top of that hill or that mountain in terms of the ethical justification?
Yeah, no, look, totally respect your position, and I think your criticisms of practices are very valid. Yes, I think this does give priority to autonomy, but we do place guardrails around autonomy. We could think of many examples, but just to take this one, I think yes, your right to donate your organs is at least in the United States now limited to a well-defined, very, very severe brain injury. What's happening in Canada is much more on that slippery slope, and I think I would share those concerns.
So one of the questions refers to research that comes out of our own institution, Barbara's and mine. There are some neurointensivists here who have done work that shows that folks who are in the neuro ICU with traumatic brain injury and are clinically unconscious actually have, I believe on functional MRI, an ability to respond appropriately. And I know from conversations with at least one of those researchers that his concern is that we're removing life support and allowing a natural death for people who cognitively might not want that, and perhaps with more time would show better recovery. I wonder, Dr. Truog, I guess this is to you, how that sort of research plays into your understanding. How do we know that an injury is sufficient to merit removal of life support, brain death or no brain death, right? Again, recognizing that you're defining brain death as a very severe form of neurologic injury. Does that research give you pause at all? And then how do you know how to draw the line?
Well, so there hasn't been a lot of research with functional MRI on brain dead patients. There was some suspicion that Jahi McMath may have developed some responsiveness over the 5 years that she biologically survived following that diagnosis, and so I do think we need to be careful. It's I think the work that's being done on covert consciousness, I think, is really important. I mean, one place where I have some concerns about the direction that research is taken is that there sometimes seems to be the assumption that if there's any evidence of covert consciousness, then we absolutely can't withdraw life support. And that doesn't make sense to me, because I think that many people would not want to continue to live where they have very little capacity to interact with others. In fact, it could be very much a form of torture. I think the research is important. I think it should go on. I don't think it necessarily threatens brain death at this point, because I think that we don't have any evidence that kind of covert consciousness exists in people who meet the criteria for brain death. It may, and if it turns out to be the case that it does, we need to pay attention to that.
Right. Thank you.
We don't have so many minutes left, but there are a lot of questions about NRP. I almost feel as though we should invite you, the two of you, back just to do NRP. But I wondered, given your perspectives, and even explaining what it is for those in the audience who may not be fully aware, having to do with organ transplantation and the harvesting of organs, and how this fits into some changing ideas around brain death. Do either of you feel comfortable saying a few words about? I know.
Actually, Bob, you're the intensivist. So I'll leave it to you if you want to just to help people understand what it is for those who aren't familiar with it first. Yeah.
Oh boy. Okay. In a sentence, we have two ways of diagnosing death: one through brain death and one through the loss of cardiorespiratory function. So NRP is in that second category. We withdraw life support. We wait for the heart to stop. We wait 5 minutes after that. And then death is declared on the basis of the irreversible loss of circulatory function. And this is where NRP gets controversial, because as soon as death is declared on the basis of the loss of circulatory function, the person is put on ECMO and circulation is restored. And so critics will say that the determination of death has been reversed. Proponents of NRP will say, nope, they weren't actually restoring circulation, in quotes. They were restoring perfusion to isolated organs. And that's a standard part of regular DCD donation. All of this in the context of, in order to do NRP, you have to clamp all of the blood vessels that are going to the brain, which some people say is just a precautionary measure to allow the process of brain death to continue unabated. Some people would say that by clamping those vessels, you cause death. Regardless of the two camps, there's no doubt that NRP has been revolutionary in terms of the quality of the organs that can be obtained. And if, we are thinking that this is somewhat my view, is that this is a person who's dying. There's no doubt about it. The decision is made to withdraw life support. They are dying. And if we can do it in a way that they want to donate their organs, and if we can do it in a way that we guarantee that they don't suffer at all, then aren't we actually maximizing their wish to be able to donate the most organs in the best condition possible by allowing NRP to occur? I'm frankly on the fence about it. And I really see both sides. However, I do think that what's driving this now is transplant centers, and they compete with each other around outcomes. They know that NRP gives you better outcomes, and I think that this is going to be a very difficult thing to stop, if indeed we even should.
Yeah, I would just also that was a beautiful description,
So you
Bob.
got a gold star for that.
Yeah, no, that was really that was wonderful. And I would just add, I would remember being very helped by the official statement of concern that was published by the American College of Physicians
Yeah.
a couple of years ago now, and in which they're candid about their assessment and saying that, as Bob just said, that death is initially diagnosed in cardiovascular terms, but then iatrogenically brain death is induced with the ligation of the carotid blood supply. And I realize others would disagree with that interpretation. I myself find that a persuasive way to describe medically, biologically what's going on.
And just to say that we aren't doing brain death testing after the carotids have been cross-clamped, which means that there may still be blood flow to the brain from posterior circulation, which means the person might not even be dead to begin with, which makes it problematic in other ways. But I had to get that in there as co-moderator. Let me end with a question since we only have a couple of minutes left. And this takes us sort of in a completely different direction, but I thought it would be nice to come back here because I had started in my own notes. This is for you, Dr. Kaldjian, but Dr. Truog, feel free to weigh in. The question, this refers to the soul as part of being human. And you seem to use soul and mind interchangeably. So the question is, that in a person who could be classically defined as brain dead and has zero cognitive function, has their soul, those things that make them human and differentiate us from other organisms, has their soul not yet left their body, is the question.
Well, it's easy for me to answer because my answer is I don't know. But there's a comment after that, and that is to say that what I didn't go on to is sort of for anyone who would share or be interested in the kind of theological background position to my position that I have, it would be to say that I don't take the universe of possibilities is not sort of held by my anthropology, but rather my belief that actually our souls are basically sustained by God, right? And that we don't have within ourselves the full resources for our own capacities, et cetera, et cetera. So we are dependent creatures. And so what the actual workings of that dependency at that mysterious moment in life are, I'm very content in my human finitude to wonder and let that be.
Great. We come back to mystery. Dr. Truog.
Yeah, that was all I was going to say is that let's not forget that much of the world in which we live and the medical practices that we have are great mysteries, and not be not be so certain to think otherwise.
Uh, I wanted to thank both of you. I also, I was thinking about coming on today, I was thinking about nature in all its glory, and diversity, and the challenge it presents us every day and trying to figure it out. Um, what a sort of odd pleasure that is, or gift we're given to be able to
Yeah.
do that. And so I have already seen in the questions some real appreciation for the wisdom that the two of you have imparted, and in particular, I think we desperately need this conversation to happen out in the open, and to have more of these types of webinars about brain death and about death. The public is hungry for it. The medical community is hungry for it. And I thank Lydia for having this idea, and thank from the bottom of my heart both of you for sharing your thoughts.